Thank you. Good morning, everyone. My name is Anirban Gupta. I'm a bariatric surgeon here at Providence Swedish Weight Loss Services. I've been in practice for about 15 years, and I'm joined with my partners and colleagues, Dr. Sarah Martin Del Campo, who's been with Swedish for approximately 7 years, and was the prior medical director of the bariatric surgical program here, and Dr. Shirish Sarab, who just joined our team recently, and he's also been in practice for about 9 years. So we're growing our team. We're excited to be here today. As stated earlier, for a variety of reasons, I decided to try a different format today. So we'll run a pre-recorded talk, and then we will monitor the chat. And then once this talk is done, then we can have a live discussion on any questions or discussion areas. So yeah, we're excited. And I guess without further ado, let's get started, if that's okay. And hopefully the technology works. So let's see. Can you still see the the video, the first screen on your screen?
Yes. Yes.
Great.
Yeah, we see the title slide. Yep.
Good morning. Thank you for this opportunity. Today we'll be providing a high-level update on various aspects of metabolic and bariatric surgery. No disclosures. Our objectives are to understand the indications, contraindications of metabolic and bariatric surgery, understand the different surgical treatment options and mechanisms of action, efficacy, safety, and durability, overall comparative effectiveness, recognize common consequences and complications of metabolic and bariatric surgery, understand the decision-making process and how insurance impacts access to care and influences the journey. We all know that obesity and obesity prevalence continues to increase for the last 40 plus years. We've seen the trends, and the prevalence in Washington state is at least 30%. Obesity is a multi-organ, multi-system disease, and stratified by gender and age. The bottom line is that as our body mass index increases beyond a certain point, our mortality exponentially goes up. So what are the indications for metabolic and bariatric surgery? Who is a candidate? The old guidelines from the NIH, 1991, BMI greater than 40 or BMI greater than 35 with comorbidities and attempted non-surgical weight reduction without success, primarily based on opinion, some experience, and little to no science. At that time, all operations were done open, which is another caveat that should be noted. New guidelines, the American Society for Metabolic and Bariatric Surgery has partnered with the International Federation for the Surgery of Obesity and Metabolic Disorders, also known as IFSO, and they've come up with evidence-based guidelines that are strongly based in science and best practice, and to a much lesser extent, opinion. The high-level takeaways are that metabolic and bariatric surgery is recommended for individuals with a body mass index greater than or equal to 35, regardless of absence, presence, or severity of comorbidities. It should also be considered for individuals with metabolic disease with a BMI of 30 to 34.9. And these thresholds should be adjusted for patients of Asian background, such that BMI greater than 25 suggests clinical obesity, and individuals with a BMI greater than 27.5 should be offered bariatric surgery. Long-term results of metabolic and bariatric surgery consistently demonstrate safety and efficacy, and appropriately selected children and adolescents can be considered. So in 2016, there was a large consensus conference, a lot of work, many publications came out of this meeting involving 45 international diabetes organizations, which essentially echoed what I just mentioned, that surgery should be recommended to treat type 2 diabetes in patients with a BMI greater than 40, 35 to 39.9, and should also be considered in patients with a BMI of 30 to 34.9 if hyperglycemia is not well controlled. And these thresholds should be appropriately reduced for Asian patients. The American Diabetes Association put out their own updated standards of care, and shown here, the bottom line is that they echo and support the same evidence and the same guidelines, both in terms of managing patients with diabetes, but also making BMI adjustments for patients of Asian background when considering bariatric surgery. Back in 1995, this paper was published by Dr. Walter Porres and colleagues. Who would have thought it? An operation proves to be the most effective therapy for adult onset diabetes. This might seem sensational at the time, but it's essentially been established and is standard of care. Swedish obesity study performed in the late 90s and published in 2004, New England Journal of Medicine, prospective non-randomized control study involving patients who underwent bariatric surgery and contemporaneously matched control subjects, over 4,000 patients with 10-year follow-up. Bottom line was the rate of recovery from diabetes post-metabolic and bariatric surgery was over 3 times that of usual care, both at 2 and at 10 years. And with more than 70% achieving recovery from diabetes at 2 years post-metabolic and bariatric surgery. Hallmark Stampede trial out of the Cleveland Clinic, 150 patients, BMI of 27 to 43, randomly assigned to maximal medical therapy versus medical therapy with surgery involving either gastric bypass or sleeve gastrectomy. Primary outcome was A1C being less than 6% with or without medications. 5-year follow-up period. In the intensive medical therapy group, only 5% achieved this primary endpoint, whereas in the gastric bypass group, about 30% achieved this primary endpoint, and 23% of the sleeve gastrectomy group achieved that endpoint. And this is demonstrated in these A1C curves stratified by therapy over a 5-year period. Shown here, the same further stratified by BMI and age. And the bottom line is that surgery outperforms maximal medical therapy. Diabetes surgery duration study, randomized controlled trial based out of 4 sites in the US and Taiwan out of 4 teaching hospitals. The goal was to see if partial or complete remission of type 2 diabetes occurs, and if so, to what extent between the 2 countries. Patients are randomly assigned, and the bottom line was at 5 years, 55% of patients in the gastric bypass group versus 14% of patients in the medical group achieved an A1C less than 7. Not surprisingly, the gastric bypass group had more adverse events. And interestingly, there was a higher preponderance of remission in patients of Taiwanese descent than in the US, but that was not statistically significant. And then there are several other studies, including this one shown here, where again, there was superior diabetes remission and control in surgical patients versus patients treated with maximal medical therapy. Furthermore, many of these studies have shown that there's a significant improvement of long-term remission of type 2 diabetes, as well as macrovascular and microvascular complications compared to control groups. The sum total of all of this work has resulted in care pathways, which essentially
demonstrate where and when patients should be considered for metabolic and bariatric surgery based on BMI, based on race, and these have become essentially standards of care based on the different guidelines. So the bottom line is that early surgical intervention is the most effective treatment for type 2 diabetes, resulting in significant reduction in medication. And the resolution depends ultimately on pre-op duration and severity and on weight loss. How does bariatric surgery help resolve type 2 diabetes? Multifactorial, but one of the major identified links in the pathway is the role of GLP-1, which has received a lot of attention with the new GLP-1 analog medications. GLP-1 has favorable impacts on the gut, on gut motility, insulin sensitivity, neuromodulation of the brain, positive impacts on the heart, insulin sensitivity in the periphery. So multifaceted impacts from GLP-1. It's produced in the ileum and the distal small bowel, stimulates insulin secretion, growth of beta cells in the pancreas, and as I mentioned, it slows down your gut motility and reduces food intake. So the bottom line is all of these different professional societies and organizations have come together, they've aligned and have generated best practices, recommended care pathways that are aligned with the latest evidence as it relates to metabolic and bariatric surgery. What are the other indications? Well, metabolic and bariatric surgery is also a bridge to other treatment, including joint arthroplasty, abdominal wall hernia repair, and organ transplantation. Undergoing this type of surgery results in significant weight loss in a healthy way, which then becomes a bridge to receiving one or more of these types of treatments and actually extending the life of the hernia repair or the joint replacement or the transplant. What are the other indications beyond weight loss and metabolic disease management? Well, we also know that this surgery results in decreased cancer risk. This was a study that was published in JAMA. The goal was to identify whether bariatric surgery is associated with lower cancer risk. It was a matched cohort study involving over 30,000 patients. And the bottom line was that bariatric surgery was associated with a significantly lower incidence of obesity-associated cancer and cancer-related mortality. And as a result, there's a significant body of work underway through partnerships between the National Cancer Institute, the NIDDK, and the NHLBI at the National Institutes of Health. So we've talked about the indications, we've talked about some of the evidence at a high level and the evolution of the guidelines as it relates to metabolic and bariatric surgery. What are the contraindications? Well, number one, drug or alcohol abuse, active smoking or nicotine use, uncontrolled psychoses, pregnancy, active cancer treatment. Other contraindications would include inadequate family or social support, unstable social circumstances, organ failure, advanced liver disease, chronic immunosuppression, particularly use of prednisone. So let's shift gears. Let's talk about the two major operations, both performed in the US and in our practice. Roux-en-Y gastric bypass and sleeve gastrectomy. I mentioned the lap band purely for the sake of mentioning it and then forgetting about it. We don't really offer this procedure. It has become essentially an abandoned procedure, but you may encounter a patient who's had a lap band. The lap band complication rate is high. It's not terribly effective. And as a consequence, it has a 50% 10-year removal rate. 1 out of 2 lap bands are removed at 10 years. So the Roux-en-Y gastric bypass pioneered in 1962, 70 to 80% excess weight loss, which translates to about 30% total body weight loss at 1 year, or 25% total body weight loss at 5 years. In terms of metabolic and other outcomes, 1 year diabetes remission approaching 60% can be as high as 86% at 5 years. And it's a pretty good operation to mitigate GERD or acid reflux as well. How does this operation work? A couple of things. Number one, it decreases one's capacity through the small gastric pouch. Number two, it decreases hunger. As you know, ghrelin is a hormone that's secreted by the fundus in the top portion of the stomach, as shown here. And when the fundus is no longer seeing food, ghrelin hormone levels drop. Third, decreased absorption, as the mixing between the food and the digestive juices, namely the acid, bile, and hydrochloric acid, is delayed until the second anastomosis downstream. So that's by design, resulting in decreased absorption. Lastly, exclusion of the duodenum results in one or maybe two different things. Number one, duodenal exclusion results in decreased or improvement in blood sugar metabolism. But number two, early nutrient delivery to the distal small bowel also potentially results in improved secretion and interaction of GLP-1 with a variety of other hormones, resulting in improved glucose control. So what I just described is the proximal versus the distal hypothesis. So what are the risks of Roux-en-Y gastric bypass? It can be stratified as early versus late. Early risks include a very small risk of death, 0.03%. We've moved the decimal. The operation has become dramatically safer and arguably safer than most other commonly performed procedures, including a gallbladder surgery, hernia repair, appendectomy, C-section, hysterectomy, or a joint replacement. Low risk of leak, low risk of bleeding, low risk of blood clot, and dehydration. Long-term risks include ulcers, which can be caused by nicotine, NSAIDs, diabetes, prior surgery, and H. pylori infection. Small bowel obstruction, which can occur at different sites or in different ways. Malnutrition, dumping, and a 5 to 10% risk of reoperation. So when an ulcer occurs, where does it typically occur? It happens at the gastrojejunostomy, the connection between the pouch and the small intestine. It may present in a variety of different ways. It may be as simple as epigastric or radiating pain to a patient's mid-back. It may cause a stricture, which may result in food intolerance, difficulty swallowing. It may cause a GI bleed, which may manifest with something as simple as anemia, or something more profound, such as frank GI bleed. Patient can also have peritonitis from a perforation. And then lastly, a gastric fistula can also be a consequence of a long-standing ulcer. Management and workup would include eliminating and identifying and eliminating underlying causes, which we mentioned. Empiric treatment with proton pump inhibitors, Carafate for symptom control, and then a referral either to a gastroenterologist or to a bariatric surgeon to perform endoscopy to rule out an ulcer. This is an example of a patient I took care of many years ago who had a perforated ulcer at the gastrojejunostomy. The differential diagnosis is not too broad. It can include an ulcer, a stricture, which can be caused by an ulcer or be caused by something else. Biliary disease, such as cholecystitis, and acid reflux. Small bowel obstruction is another consequence of gastric bypass. It can occur anywhere along the small intestine or at the jejunostomy, and there can be different types or flavors of small bowel obstruction, such as an adhesion or a hernia or an internal hernia or an intussusception. Patient may present with pain, nausea, food intolerance, and typically when this occurs, it's an abdominal or rather a surgical emergency and may oftentimes result in an operation. Shown here are 3 different causes or types of small bowel obstruction as mentioned. Top left, intussusception; on the right, hernia through the abdominal wall; and then on the bottom left, different areas where small bowel can internally herniate. As mentioned, nutritional deficiencies can occur after gastric bypass, can generally be avoided with a high quality diet, taking one's vitamins, long-term follow-up with the bariatric team and primary care, as well as annual labs and blood work. Should be mentioned that thiamine deficiency, if unrecognized or untreated, can result in Wernicke's encephalopathy. Hallmarks are essentially a patient who is malnourished or having food intolerance and presents with mental confusion, ataxia, or ophthalmoplegia. And the cause is, as mentioned, a thiamine deficiency. These patients should be appropriately replenished and should not be given IV glucose in the absence of thiamine, because that could make things worse and cause a Wernicke's encephalopathy. Switching gears, let's talk about the sleeve gastrectomy. It was pioneered almost 20 years ago. Most popular procedure today due to its relative safety and efficacy. Weight loss outcomes, 60 to 70% of excess weight loss. In terms of total body weight loss, that's 25% at 1 year. It can drift down to 18% at 5 years. In terms of metabolic outcomes, 1 year diabetes remission is about 56%. And the 5-year diabetes remission is about 84%. How does this operation work? A couple of things. Number one, you have less space, 4 to 6 ounces. You have decreased appetite because of decreased ghrelin secretion. And then some would also argue that there's improved emptying as well. Risks similar to that of a gastric bypass. For the average risk patient, 30-day risk with a sleeve actually tends to be lower than what we see with gastric bypass. And then long-term risk also tends to be lower. You typically don't see an ulcer, a small bowel obstruction, dumping, or malnutrition with the sleeve gastrectomy. So what's the downside? Well, the downside of the sleeve is the issue of acid reflux. There's at least a 30% incidence of GERD long-term with a sleeve, and up to 10% of patients, as a consequence of GERD that does not get better, may require a conversion to a gastric bypass to mitigate reflux, since gastric bypass can make reflux better. Shown here is a high-level overview of comparative effectiveness between the different treatment modalities. 3 different metrics: safety, efficacy, durability, and we're comparing lifestyle versus pharmacotherapy, sleeve, and bypass. From a safety perspective, obviously lifestyle, diet, and exercise is safe. Pharmacotherapy is safe. There's some side effects, the main things being with the GLP-1 drugs, nausea, and sometimes diarrhea. The safety profile, as described earlier, is quite good with sleeve versus bypass. 1 to 2% risk of short-term complications, and essentially 3 to 6 or 7% risk of long-term complications for the average risk patient. In terms of effectiveness, total body weight loss with diet and exercise for the average person, 5 to 6%, best case scenario. Pharmacotherapy, we're still learning, but looks pretty good, 15 to 20%. Sleeve, 25 to 30%. Gastric bypass, 31 to 36%. Diabetes remission, generally quite good with bariatric surgery, as discussed earlier, 56 to 84%, or as high as 86% for gastric bypass. The remission rates are significantly lower with intensive medical therapy, somewhere between 10 to 15%. Durability. Essentially, diet and exercise, at least 95% of patients will regain their weight. If you stop taking medications, you'll regain your weight. Compared to sleeve or gastric bypass, the likelihood of weight regain is much lower and typically impacts about 15 to 20% of patients. But mind you, this is not complete weight regain. This is some weight regain, typically somewhere between 5 to 7% weight regain. Lastly, how about non-response as a measure or a surrogate for durability? What percent of patients will just simply not respond and regain all of their weight? As mentioned, diet and exercise, 95%. Sleeve, it's about 10%. And gastric bypass, about 3%. So certainly if durability is the goal, then gastric bypass gets first place. So bottom line is there's room for all of these options. Obesity is a chronic condition. Survivorship or durability is improved with integration and utilization of all the different options which we offer here at Swedish Providence. And options are important. Diet and exercise is a pillar for all of our patients. Long-term follow-up is critical for long-term success, and pharmacotherapy plays an important role as well. So let's switch gears. How do we make decisions on our patients? Well, number one, it involves shared decision-making, preference-sensitive decision-making using the best possible information to guide our patient. We need to integrate our patient values. What are their healthcare goals versus risk tolerance and comfort? Or what are the unique patient factors? Do they have GERD? Do they have NSAID reliance? Or what other factors may influence their choice? What are their disease factors? What is their BMI? Are they diabetic? What other conditions do they have? And then we match these factors with the right procedure, utilizing some tools. Furthermore, we try to engage best practices and processes in our clinic. So for example, all of our patients have one-on-one meetings with surgeons, APCs, dietitians, psychologists, nurses, navigators, and other stakeholders on our team. And then internally, we also have multidisciplinary team meetings, case conference, surgeon, nurse, navigator huddles, and surgical team meetings on a weekly basis. Shown here is an example of an MBSA QIP risk-benefit calculator tool. It essentially is a publicly available tool. Anyone on this meeting can access this tool. You integrate your patient's operation of choice, their height, their weight, age, gender, ethnic background, ASA class, a variety of other comorbidities. And essentially, using big data, this tool will calculate your patient's 30-day risk of complications, sleeve versus bypass, or duodenal switch. It'll also calculate their one-year weight loss trajectory in terms of actual weight lost, total weight loss as a percentage, and BMI change. And then last but not least, it'll also predict comorbidity remission over the next 12 months. So it's a powerful tool, and we use this when we see our patients for the first time to facilitate decision making. Speaking of tools, Cleveland Clinic, not surprisingly, has a whole suite of tools that we can use and at times we do use to help inform the conversation when we're trying to figure out what's the best choice for the patient sitting across from us using a data-driven methodology. So speaking of data, let's talk a little bit about decision trees. So for example, if the question we're trying to ask is what is the optimal decision, facing the person sitting across from us, the patient. So what is the best operation? Well, using decision tree theory, that's our decision node, something that we have control over. And then the next thing we do is we apply a state of nature, something that could happen after a decision is made with a certain possibility. So that's our chance node. And then lastly, we have our payoff node for each scenario. That's the quantifiable value of a desired outcome. So for example, for one patient, the desired outcome or focus might be optimal weight loss, defined as total weight loss or as a percentage total weight loss. For another patient, perhaps they are more focused on complication avoidance. And for the purpose of this talk, we'll define that as a 1 versus 0, two different binary variables. So we put together our decision tree, and we'll talk about it in the next slide. And then we calculate the expected values at each node and compare which decision provides us the max or minimum until we get to the initial decision node. And the outcome is the presumed outcome if the same decision were encountered thousands of times. So let me explain. So as you can see in this diagram, we start with the first action, which is we make a decision. Does the patient undergo a gastric bypass or does the patient undergo a sleeve gastrectomy? And then once that decision is made, and we're reading this figure from left to right, then the next thing that occurs is we apply a state of nature shown here. And the state of nature is a complication or no complication. So we're saying with a gastric bypass, there's a 5% risk of a complication and a 95% or 95% risk of no complication. Similarly with a sleeve, we're saying there's a 2.5% risk of a complication and then the associated payoffs with each pathway. So for example, if a patient undergoes a gastric bypass, they might have a payoff of 31% total weight loss versus a lower weight loss payoff if they undergo a complication. And we've done the same thing here for a sleeve with 25% total body weight loss if they have no complication. And then we've arbitrarily assigned a slightly lower weight loss as a payoff in the event that they do have a complication. Once this is done, we have our payoffs, we have our states of nature, we have our decision variables. And so now we start from the end and work backwards. So what we do is we essentially take the payoff and we multiply it by the probability of occurrence for each state of nature and add those together. And that gives us, that sum product gives us the expected value. So the expected value for a gastric bypass is 0.3075 versus the lower number shown here for a sleeve. That tells us that if using the decision tree model, if the primary goal is to lose optimal weight, then logically the best operation would be a gastric bypass. Conversely, if we apply a different payoff, if we said, you know what, we're actually going to prioritize risk avoidance, as shown here in the last column. So the payoff is risk avoidance, 0 versus 1. 1 means you avoided a complication. And we did the math, we worked backwards from the end, then you'll see that the expected value is actually higher for a sleeve than that for a gastric bypass. And so essentially what the decision tree shows us is a couple of things. Each patient has a different internal set point in terms of how they value the different payoffs. Weight loss or metabolic disease improvement versus complication avoidance. Each surgeon also makes similar decisions on balance between desired outcome and risk avoidance. And if the two factors that we just walked through right now were not the case, and if the sole focus were weight loss and metabolic outcomes, then if we were to apply essentially simple statistics and probability and the logic of decision trees, then we would be doing gastric bypass probably 100% of the time. All right, a lot of material, but we're almost in the home stretch here. Let's shift gears and talk about insurance. Insurance impacts access to care. Each insurance company has different requirements, qualifying conditions, timeframes, specific needs, such as a period of time during which a patient must spend in different ways with the bariatric clinic, commonly referred to as medically supervised weight loss. And lastly, Medicaid has very specific requirements, which creates confusion and puts a higher burden both on the patient and on our referring or primary care colleagues. So we're going to talk a little bit about all of that. This is a busy slide. We recently reviewed the insurance requirements and qualifying conditions of a variety of our commercial pay insurances in this market. So I invite you to take a look at this later on. It's got a lot of pretty helpful information. And again, it's updated, but these things change all the time. But it'll give you a good insight into what's happening in the space. So this is a similar slide which shows the requirements, medically supervised weight loss, time frame, qualifying conditions for patients who are Medicaid beneficiaries versus Medicare beneficiaries. So what's the bottom line of all this? Well, we're seeing a couple of things. The insurance companies are adopting the evidence-based guidelines. Providence Health Plan, for example, they haven't changed their BMI criteria. However, NASH, GERD are considered comorbidities for PHP, which is forward thinking. Cigna has made BMI adjustments for Asian race. They accept degenerative joint disease as a comorbidity, pulmonary hypertension, lymphedema, GERD, similar to Providence Health Plan. Blue Cross Blue Shield of California, probably the most progressive. They have made adjustments for BMI. They accept GERD as a comorbidity. They also, interestingly, require attempts of weight loss through other means, including pharmacotherapy, hence acknowledging the role and the importance of pharmacotherapy in this space as well. Aetna also has made adjustments for Asian race, and they've also acknowledged NASH as a qualifying condition and have even made some helpful suggestions on how to make the diagnosis of NASH. Premera, interestingly, is the only payer which has acknowledged that patients with a BMI of 30 to 34.9 with type 2 diabetes with inadequate glycemic control should be considered for bariatric surgery, in alignment with the guidelines that we talked about earlier today. One of the Medicaid products out there, Apple Health, again, a variety of adjustments to their guidelines, BMI adjustments for race, as well as comorbidities, including type 2 diabetes, insulin resistance, prediabetes, metabolic syndrome is a qualifying condition, venous stasis disease, urinary incontinence. If you have a patient who meets the BMI criteria, but doesn't have any of these other comorbidities, but has been disqualified from another surgery, such as a joint replacement, abdominal wall hernia repair, or an organ transplant, then that patient may also qualify for bariatric surgery. Medicare, again, they've decreased the BMI threshold to 35. with one comorbid condition, including PCOS or a variety of other conditions as noted, and incontinence. So bottom line is the insurance companies are coming along, but we still have a long journey ahead of us. Lastly, Medicaid, unfortunately, as discussed, has made it challenging for the patients and for primary care. Essentially, it comes down to appropriate documentation, filling out forms, and submission of those forms to insurance companies or to Medicaid to enable a patient to qualify for stage 2 approval. And once the stage 2 approval is received, then and only then can we see Medicaid patients. So stage 1 is essentially time spent with the patient and the referring practice. And the referring practice has to submit documentation that substantiates that the patient meets the requirements put forth. And then once the authorization is received, then the bariatric surgery practice can see those patients. We've created some communications and happy to send those your way, as well as some links to the different forms to try to decrease the burden of this work for our referring partners. So speaking of partnership, all of this work takes a team, and I'm proud to say that we have a fantastic team partnering with each other, partnering with you. You've met some of my colleagues here, my partners, Dr. Sarah Martin-Del Campo, Dr. Shirish Sarab, our PAs, Jen Strumalo, IJ Okeki, Eric Betson, and Kat Koza. Various other members of the team, including our dietitians, Margot, Brittany, Dr. Julie Wieselmeyer, Dr. Haley Hemphill, our psychologists, Margot, another one of our fantastic PAs, Lacey, one of our nurse practitioners, and then, of course, nothing happens without good leadership. Scott Watanabe, our clinic manager, Brianna Jocelyn, our clinic supervisor, and Gennard Peregrino, our program manager. We also have a very comprehensive medical weight loss program led by Dr. Enrica Basilico. So she's my dyad partner as medical director of the medical weight loss program, and Dr. Michelle Rappaport and various other partners on the medical weight loss side. So we all work very closely together. So thank you for affording us this time and the opportunity to go over a lot of information with you in some.
All right, so again, thanks for the opportunity. We covered a lot of information and happy to take any questions.
Well, thank you, Dr. Gupta, for just a great summary. And I think that recording worked just fine. And thanks for spending your time with us after a busy night yourself. And I'm not totally sure if the chat, Sarah's the chat up and sort of running, or if people just want to unmute and ask a question, that'd work too.
There is a question. Would you please touch on follow-up recommendations post-surgery?
Sure. I'll start kind of broad and then distill down on specifics, and then also encourage my partners to jump in as well and fill in the blanks if I miss anything. Follow-up is critical to success for our patients. What we tell our patients is when you marry a complex procedure with a chronic medical condition or set of conditions, then long-term follow-up is super important. We typically have a very structured follow-up cadence post-bariatric surgery in terms of a phone call within a few days after surgery, 2 weeks, 3 months, 6 months, 12 months, and then annual for life. So those are kind of the high level recommendations for long-term follow-up. Blood work should be checked typically at least twice in the first year of bariatric surgery, and then subsequent to that annually for life in terms of labs. There's a good paper, which I can't name, but it's essentially a compilation between bariatric surgeons, dietitians, and other stakeholders that have put together a very detailed set of recommendations on monitoring nutritional parameters, labs, et cetera, post bariatric surgery, which I can certainly follow up with you on. But those are kind of the general recommendations for follow-up.
I'll just add also that the studies have shown that the patients who are most diligent in that follow-up also tend to have the most long-term success. And part of that is because in thinking of obesity as really a chronic disease, the surgery itself is one time point in treating that disease, but at some point in time, it's really going to transition to not just being the effects of the surgery, but the overall dietary and behavioral modifications that patient's going to take with them long term. And that part takes practice. And so coming back to see our team working with the dietitians, the medical providers on a routine basis long term is really the key to ultimate success, 5, 10, 15, 20 years later.
Yeah, I agree with what Sarah and Dr. Gupta said. I think compliance is the key. So, post-op follow-up is very important, not only with the providers, but also with dietitian, and having a strong mental health is also very important for long-term success. So we highly recommend following up with their counselors or psychologists after surgery.
There is another question. Can you speak to what happens at the medical weight loss clinic?
Yeah, absolutely. So essentially, the medical weight loss team is comprised of a multidisciplinary team of medical weight loss physicians, MDs, nurse practitioners, PAs, dietitian, and psychologist. And they tailor their care to the needs of the patient because every patient is different. Typically, patients who go to their clinic are patients who want to lose weight and or improve their diabetes, but don't qualify for metabolic and bariatric surgery, or are not interested in bariatric surgery. And so those will be sort of the typical patients that go. The third type of patient that will meet with the medical weight loss team are patients who are actually interested in bariatric surgery, but might be too high risk because of their excess weight. And so they might meet with the medical weight loss team first to lose some of that weight before we consider surgery. And so typically their focus is a combination of pharmacotherapy, nutritional counseling, psychologic evaluation, and then the usual adjuncts of lifestyle changes and exercise. And so those are sort of the main offerings of the medical weight loss team, and we all work together.
I have a question. This is Mark Fisher in Port Angeles. As you look at the next, few years or several years, you undoubtedly are keeping your eye on the dashboard of the newer weight loss medications. And what do you want to do a little projecting as to what the cadence is with this, and what in your arena this might lead to as it relates to options for patients? So whether they're medical or surgical, just sort of a bit of a projection, so to speak.
Yeah, I'll share this is purely, I would say, educated opinion, because we're still in the early stage of the GLP-1 drugs, and then interested to hear what Dr. Sarah Martin Del Campo and Dr. Sarab think as well. But my view is I think these medications are really going to revolutionize this space in the future. It's already happening. These medications, unlike the prior generation, really go at the heart of the how, right? The mechanistics, the mechanism of how and why obesity and metabolic disease can occur. And so they're, as a consequence of that, they are highly effective. Their effectiveness is almost, in some cases, as good as a sleeve gastrectomy. So it gives patients and physicians choice, which is important in this space. Going back to the concept of shared decision making and preference sensitive decision making, one person's values and priorities may differ from their neighbors. So giving them choice is important. I think the barriers in the short term will be, of course, insurance, cost, access. Pharmacotherapy tends to be a lot more expensive in the US than many other countries. But with time, that might change. And I suspect in the next 10 to 15 years, maybe less, we'll get to a point where a patient might be taking Lipitor, semaglutide, and some other medication for their blood pressure, and it may not even be a thing, right? We accept that it's okay to chronically take medications for heart, medications for blood pressure, et cetera. And so these medications may also occupy that same space in the future.
It looks like someone asked a question specifically sort of around the workarounds when insurance doesn't cover some of these medications. And to Dr. Gupta's point, I think that that's certainly one of the biggest challenges is access to these medications. Our clinic doesn't have any specific workarounds these days in the sense that there had been some things worked out where patients could go to Canada and get medications and things like that. But Canada actually shut that down about 2-3 months ago when it came to Ozempic, semaglutide, Wegovy, those types of medications because of their own limited access. So I don't know that we have any universal tips on how to get these things approved other than we're going to just keep working and fighting with these insurance companies to make these things more accessible.
Yeah, to the previous question, I would just add that, I wouldn't see all these medications as a competition for surgery. I think they are adjuncts. And like everyone said, it's obesity is a chronic disease. And like Dr. Gupta said, you want to treat it. And in the next 5-10 years, people will have better acceptance for the fact that it's a chronic disease. So it's okay to take a medication just like you would do for diabetes or high blood pressure. But I think it's exciting because, it's a chronic disease. And right now we basically treat 1 or 2% of the actual patient who would benefit from some kind of weight loss treatment. So I think it'll improve access, getting more education about obesity and as a chronic disease treatment options. So I think it's good for the overall treatment for obesity. I think all these medications coming up.
We have one question here from Dr. Kennedy.
Hi, thank you very much for this excellent presentation. Another insurance question. Are you seeing a big difference between straight Medicare and Medicare Advantage in the pre-authorization process?
So interestingly, Medicare actually doesn't do a pre-authorization on surgeries. It's all on the post side of things. And so with that, we have to be very careful to make sure we are meeting all of their criteria on the front end to ensure that on the back end it gets paid for essentially. But no, actually, between the various Medicare plans, essentially, it's that 4-month medically supervised weight loss requirement and similar BMI criteria. But they are the one insurance plan that also, because they don't have that pre-authorization, that BMI day of surgery is incredibly important for us.
Right. Those patients could potentially, ironically, disqualify themselves from surgery if, as they're going through the 4-month preoperative program with us, if their BMI drifts beneath 35 by the day of surgery and we do the operation, then the patient may end up with a massive bill and the hospital won't get paid because the authorization occurs on the back end after the patient has received their surgery, unlike every other insurance that we mentioned.
Well, thanks again so much. And thanks for your attendees joining us this morning, both from Olympic and from Jefferson and Port Townsend. And we look forward to seeing you in September. And thanks for closing out the first half of the year with just a great summary and a great talk.